is that 45% of adult population never get their blood pressure checked. 78% of the adult population never get their blood glucose level checked. 90% of the adult population never get the lipids checked. So that's the state of affairs. And only 50% of those who have high blood pressure are taking their medications regularly. Now, as far as diabetes is concerned, just 10% have their diabetes well under control. And 60% of adult Pakistani population fall in the category either they are physically inactive or do very light physical activity. And about 46% of our population is overweight, and most of them are actually females. And 30 to 35% of adult population, they use tobacco in different forms. And in some groups, the use of tobacco is about 75%. And the average age of starting smoking is about 21 years. Now I come to the part 2 of my talk. We'll talk about risk factors and how to control them. Start with hypertension. We know that about 62% of the strokes and 49% of the coronary artery disease are attributable to suboptimal blood pressure. Now, the problem in our part of the world is that in South Asia, the blood pressure has increased over the past decades by 0.8 millimeter in men and by 1 millimeter mercury per decade in women. This is opposite to the Western world, where the blood pressure has been falling. So this is a very important risk factor. The problem with hypertension is that most of the people, they remain undiagnosed. And those who are diagnosed, half of them do not have their blood pressure well under control. And these control of hypertension is especially poor in the elderly. Now, if a person gets hypertension, this is about a white, male 35 years old. And if he gets hypertension, say about 35 of age, he will lose about 16 years of life. If he has blood pressure of 150 by 80. If he has 130/90, that's we normally take as the normal, open normal, still he will lose about 4 years of life. Now there are more how to control blood pressure. There are non-pharmacological and pharmacological treatment. So a couple of slides about how to control blood pressure by non-pharmacological means. That includes weight reduction, healthy diet, reduce intake of dietary sodium. The optimal goal is about 1500 milligrams. As we know, the first speaker, Dr. Shakil Mirza, he mentioned about that. And then we need to enhance intake of dietary potassium. Then we need to do aerobic and dynamic, aerobic physical activity. Then we need to reduce alcohol consumption where it is there, So these are the non-pharmacological approaches to treat hypertension. As far as hypertension control is concerned, it is the magnitude of blood pressure reduction that determines risk more than the drug choice. So it is not the drug which is important, it is the degree of reduction of blood pressure which is important. And it's important to understand even small degrees of decrease in blood pressure, they matter a lot. There are large benefits. And then, the drugs which include for treatment of hypertension are ACE inhibitors, RBRBs, better than myself. Next is smoking. Ischemic heart disease causes about 35% to 40% of all smoking-related deaths. There are about 1 billion smokers worldwide. By many accounts, this is the single most preventable cause of death in the world. And it's very, again, important to understand that most of the tobacco use is now occurring in the low and middle income countries. That is where Pakistan belongs to. And all kinds of smoke that includes BDs, hookah, smokeless tobacco are all linked to this increased risk. And secondhand smoke is another well-established cause of coronary heart. That secondhand smoke is that if you are sitting next to a smoker, you are not smoking yourself, but you are inhaling the smoke. And on average, a smoker loses about 10 years of life. Now, if you stop smoking, the benefits are immense. And those who quit smoking, the risk is down about 50% in 2 years. And in about 3 to 5 years, the risk becomes equal to that of about non-smokers. And even elderly, those, some patients come, look, I've been doctor, I've been smoking for 50 years. Why should I stop now? Even the elderly benefit from cessation of smoking. It's never too late. And once again, I say that cessation of smoking remains the single most important intervention in preventive cardiology. These are the different, replacement therapy that are available. Now, how do we, control tobacco? There have to be they have to be effective mass media campaigns to educate people. Then government should be providing support and advice to population. Then there has to be increase in taxes and prices on tobacco products. And then the government has to enact and enforce comprehensive bans on tobacco advertising, promotion, and sponsorships. And then we have to eliminate second-hand tobacco in all indoor workplaces and public places and public transport. Now, this was ad which appeared in on 26th of June in the newspaper, the first page. The ad said that there are about 1,200 children who take up smoking each single day in Pakistan. And then look at the amount of increase in the taxes on the foodstuff. The taxing going up, and on the smoking, there has been no increase. I was just talking to Snaula Sahab, and he just informed me there has been no increase in the tax even this year. And tobacco taxation reduces its consumption. And presently we have a revenue loss of about 15 billion rupees. Now next comes the cholesterol. High cholesterol causes about 56% of ischemic heart disease in the world. Low density cholesterol is central to the plaque genesis, progression, and instability. There is no doubt about that. And reducing the cholesterol may even eliminate the ischemic heart disease. There is no longer in the that reduction of LDL cholesterol levels has a role in the prevention of and treatment of coronary artery disease. There have been large number of trials on the primary prevention, and they have all shown that the reduction of lipids leads to benefit. And the question is, how should early be treatment started? It is now recommended that we should be screening the children, and all of them who have high lipid levels should be treated with statins. And what is the level of target of LDL? I'll just give you an example. In the Arctic Eskimos, that is a place in the world where there is no ischemic heart disease, and the level in Arctic Eskimos of LDL level is about 50 to 70 milligrams. So that should be the target. We achieve that level in our population, we can eliminate coronary artery disease. So sooner the better. There have been a lot of talk about side effects of statin, and this is a very scientific statement that benefits of statin therapy on myocardial infarction, stroke, revascularization procedures, and cardiovascular death outweigh the risk even for those who are at the lower end of the absolute risk spectrum. Now, diabetes, it has already been mentioned by Professor Shakil Mirza in his talk. The incidence has increased worldwide. And the problem with diabetes is that 50% of the diabetics, they remain undiagnosed. And 80% of the diabetics, they live in the low and middle income countries. That is Pakistan. And 90% of the type 2 diabetes cases relate to obesity. So obesity coexists with the diabetes. And it is now being said that Asian population may have a higher risk for developing diabetes even at a lower BMI due to visceral obesity. That is kind of specific to our region. Now, the day you are diagnosed with diabetes, you should consider that you have gone older by 15 years. That if you are diagnosed a diabetic at the age of 50, then that means you are 65 years of age. That is your biological age. And those who are diagnosed with diabetes, they have a 2 to 8 times increased rate of future cardiovascular events. And 75% of all deaths in diabetes are because of coronary artery disease. And the risk of cardiovascular disease starts to increase long before the onset of clinical diabetes. That means there is a prolonged period of hyperglycemia when they are not actually diagnosed. The risk starts with hyperglycemia. Now, how do we treat diabetes? It's very simple: diet, exercise, then oral tablets, then insulin, and then a couple of these new drugs. They have been related with the decrease in the risk of cardiovascular disease. Ultimately, aim is to achieve an HbA1c level less than 7. And poor control of diabetes in our country is a major challenge for us. Now, this is a study that if diabetics, they control their weight, their smoking status, their blood pressure, and diabetes, there can be reduction in the incidence of coronary artery disease. So, if we achieve good control and have a healthy lifestyle, diabetes can avoid ischemic heart disease. Now, obesity, as of 2016, there we have figures, complete figures. 13% of adults globally were obese, with rates as high as 40% in many countries. And the prevalence of obesity is increasing. And more than two-thirds of deaths related to high BMI were due to cardiovascular disease. Now, currently, we have some drugs being recommended for the control of obesity. Obesity, again, is a common childhood problem also. And obesity in childhood is associated with cardiovascular disease in adults. So, as parents, we need to control childhood obesity. And, cardiovascular risk in adulthood is reduced if obesity is treated or prevented in childhood. Now, physical inactivity. Now, what has happened there? There has been urbanization and industrialization. There has been a shift from physically demand, like plowing in the field by the farmer himself, but now he's got tractors, and moving from sedentary office jobs. So there has been a switch to less physical inactivity, which is an independent risk factor. Now, if we increase, if we do about 150 minutes of exercise per week, we can reduce the incidence of a coronary artery disease. Just let me just run through. She's telling me we are short of time. So there are a couple of non-conventional risk factors, non-conventional, because there are about 50% of patients in whom we do not understand why the ischemic heart disease has happened. Now, the new thing about aspirin is that we used to recommend aspirin for primary prevention no more. The risks of aspirin are more than the benefits. So it has to be prescribed only in high risk population. Then diets and supplements, they can improve health. Mediterranean diet has been linked with the decreased incidence of coronary artery disease. There was a lot of talk about DASH type diets, but now it's known that because of its dairy content, it's not as effective as the Mediterranean diet. This is kind of food plate we should have: healthy oils, water, whole grains, healthy protein, fruits, and vegetables. And this is kind of the chart which shows that how can we prevent ischemic heart disease by food alone. Now, women, more than 50% of population is women and heart. There have been not great amount of research on women. Overall, 1 in 3 women die of cardiovascular disease, and 45% of women more than 20 years of age have some form of cardiovascular disorder. They have some unique, disorder like polycystic ovarian syndrome, premature menopause, during pregnancy, if they have a pregnancy-induced hypertension or gestational hyperglycemia, they're all linked to increased risk of coronary artery disease later on. Yes, these are the main 7 things which need to do to prevent heart disease: control blood pressure, have physical activity, avoid use of aspirin where it is not indicated, control diabetes, healthy diet, and avoid tobacco. Now I come to the last part of my talk, that is how to do it in our part of the world. There have been 3 types of intervention in past. One is the one who targets those who have established coronary artery disease, and then second targets the person who are at high risk because of multiple risk factors. The third strategy is using mass education or policy intervention directed at the entire population. So we need to change our current policies. So the traditional approach has been to treat those who have heart disease, prevent, that is secondary prevention, then go for control of risk factors, and those who have high amount of risk factors, give them advice. And there have been different scores which have been used. There's a Framingham score. There have been the other thing that we do in could take stock of during the calculation of different scores. And then all these scores, they require a lot of laboratory, CRPs, cholesterol levels, sugar levels. They have been risk scores which have been developed by WHO for the poor countries, which just take into stock weight, diabetic status, and hypertension, etc. But there have been these traditional interventions, they have been going on, but they have not been, the incidence still rising. So what we need to do? We need to shift to mass prevention. That means prevention for all. Because most of the coronary events, they occur in low risk people. And trials have shown that benefits of therapies in low risk people, like these are trials. And currently what is recommended is we should, go for prevention for all. And how can we do it? We have to make policy changes, legislative changes, like salt reduction in processed food for all, reduction in exposure to smoking, alcohol control, fast food. They have got bad kind of foods. It requires substantial investment. There had to be governmental action. Unfortunately, government decisions are at times political, and they often meet resistance. And UN Assembly in 2014 acknowledged that there was a slow, insufficient, and uneven progress in the mass strategy prevention programs. Now, I'll just tell you how it's difficult to change policies. It was known in 1950 that smoking is linked with lung cancer, and it took about 19 years for the government to pass an act which will, prevent cigarette act. This is a very low amount of health spending in our part of the region. Now, the mass strategy, what does it include? It includes, ischemic heart disease, prevention of ischemic heart disease, stroke, diabetes, and cancer as well. There has to be mass media campaigns on radio, TV, on print and social media, and use of mobile technology. As far as mobile technology is concerned, there are no counterproductive stakeholders. An app-based primary prevention strategy carries virtually no cost. There has been some success in these because everybody carries a mobile. Everybody has, a lot of these apps. They can download those health apps. They can count their exercise, their steps, their, time spent in the, in the gyms. And people can get messages from the government on mobile. So mobile is the key thing to prevention of coronary artery disease. Now, what is AFIC doing about primary prevention? As we know, PANAH was established at AFIC and it has done great work since last 30-40 years. We have a preventive cardiology department. We have a research and development department. We have been conducting surveys and research papers, and AFIC has been delivering education lectures in different universities, cantonments, colleges. There have been a lot of publications, and finally, we are trying to establish a National Center of Excellence in Prevention, Cardiovascular Research and Development. And it is going to conduct community-based research. There's a lot of lack of data in policy making. We are going to provide that data which will help in making government the policies. And we are going to have linkages. We have made linkages with all the provinces and all the major government institutions and the private institutions. And we hope that it will act as a think tank on prevention of cardiovascular disease through collaborative research to facilitate health and to facilitate health policy. That means we do research, we draw conclusions, we make recommendations, and then that the Ministry of Health will make policy, and ultimately the primary prevention will be implemented. We further plan to establish a facility where outcomes research can be translated into tangible services and products, and impart skills and develop expertise through requisite resource provision and training and capacity building. This is AFIC, and that's the area where NEPGARD is going to be. This is a PEMH, and that's the Armed Forces of Ophthalmology. This is the future building that we're going to have. So what's the take-home message today? If we want to prevent ischemic heart disease, most important is healthy lifestyle. Primordial prevention. Primordial means that we prevent the risk factors to happen, like we prevent diabetes, we prevent hypertension. We start prevention from the birth of the baby. And this healthy lifestyle should continue throughout the life. We should have a risk estimation for all who are more than 40 to 75 years of age. We should promote healthy diet and ideal body weight. We should encourage physical activity. And for diabetics, these lifestyle changes are critical. We should avoid tobacco, aspirin for high risk only, and statins are the first line treatment in those who have those who need primary prevention and those who have higher risk. And we should forcefully employ non-pharmacological intervention for hypertension, and ultimately it has to be a team-based care approach. Thank you very much. There any questions? So we'll take okay. Thank you very much.
Thank you so much, Sir Farhan, for such an informative and enlightening talk. Now, moving on to our next discussion, we have Honorable Dr. Nicholas Pentazopoulos. He is consultant cardiologist at West Middlesex University Hospital, Chelsea, and Westminster NHS Foundation Trust. He'll be connected to us virtually, and Dr. Nicholas will be discussing about cardiovascular fitness and heart diseases.
Hello, good morning. Thank you very much, everybody. Thank you to PANAH for inviting me to the conference. I'm very grateful. So let me just share my screen so that you can see what we will be talking about. So hopefully you can see my screen now. Thank you. Right. So the talk is about cardiovascular fitness and heart disease. My name is Dr. Nick Pentazopoulos. I'm a cardiologist in London at the West Middlesex Hospital. I'll try not to go over time if possible, but please forgive me if I do a little, and I will try to give you a British perspective. I'm actually very interested to hear from the previous speakers that the problems that we have in our part of the world are very similar to the problems that you have in yours. So let me first tell you a couple of things about myself because I'm from overseas, so you don't know me. So I trained in Australia, in Greece, and in the US. I've been a cardiologist in London for 15 years. I specialize in cardiovascular imaging. I've got quite an extensive teaching experience. And I also am a member of the Football Association and fitness train professional football players. I run international educational programs in Asia and in Africa. So this is me teaching in Wuhan, China, in the days before we had COVID. My disclosures. Now, I do have as a pet hobby history of medicine. So despite the fact that we're talking about cardiovascular fitness, I'll tell you very quickly a couple of things about the history of heart disease that you may think are fascinating. So Egyptian mummies were found to have atherosclerosis. So the pharaohs have been known to die of heart disease. Obviously, the pharaohs had a very soft lifestyle. They had everything done for them. So as a result, they were plagued by the same problems of poor lifestyle that we have today. Now, it's difficult to know when exactly humans became aware of heart disease, but angina was described in 1768. Osler realized that it was a syndrome rather than a disease, and in 1912, James Herrick in the US concluded that it's the narrowing of the coronary arteries that caused angina, and he invented the term heart attack, and here's Dr. Herrick here. Now, in the 20s, we started to experiment with catheterization, and slowly we gained more techniques until Mason Stones, who was a pediatric cardiologist at Cleveland Clinic, perfected the technique, and here he's performing his catheterization. So when did we start watching our diet? So as the previous speaker mentioned, in 1948, we initiated the Framingham Heart Study to understand heart disease. In 1949, the term arteriosclerosis, which is atherosclerosis, was added to the International Classification of Diseases, and this resulted in a sharp increase in reported deaths from heart disease. Of course, that was statistical simply because it was being measured rather than real. In 1950, we noted that high levels of LDL and low levels of HDL could cause atherosclerosis. And also in the 1950s, we discovered that heart disease was lower in the Mediterranean and the Japanese populations who had, of course, low-fat diets. So this is how the low-fat diet was born. So this is a little game that I like to use. What are the three first words that you see? So if you read along the lines, you see some people may read love in the top line, or you may see youth in the third line. But if you go further down to the fifth line, you see that the last word is health. So I always put this when I teach my students, and I see how many of them see health as the first word. Unfortunately, it's not all that many people, which is rather disappointing. So what causes heart disease? Well, we've mentioned that. It's sedentary lifestyle, genetics, of course, smoking, and old age, amongst other risk factors. So do we care about ourselves? Well, the British Heart Foundation in 2017 said that we don't. Around 20 million adults in the UK are inactive, and that's 39% of UK adults. This is not just people who have inadequate levels of exercise. These are people who do not exercise. Overall, women are 36% more likely to be classified as physically inactive than men, and 60% of adults are unaware of the government's physical activity guidelines. So as a result, we've got a bit of an obesity epidemic in this country. So 30% of children aged 2 to 15 are overweight or obese. I personally think it's tragic. Out of 100 4 or 5-year-olds in England, 13% are overweight and 13 are overweight and 10 are obese. Out of 10 to 11-year-olds in England, out of every 100 of them, 14 are overweight and 20 are obese. So we're not really doing very well. And as a result, in 2015, 63% of adults in England were overweight or obese. So the rate of obesity is going up rapidly, unfortunately. So it's not very good news. And speaking of Pakistan, and I believe the previous speaker mentioned it very, very eloquently, unfortunately, the problem is also prevalent. So in 2014, global disease estimates showed that Pakistan stood at number 8 among the top 10 countries hosting half the obese individuals in the world. 25% of adults were overweight or obese. And again, in women, it's the prevalence in higher in the 35 to 44 year age group, and for men a little older in the 45 to 54 year old age group. And residents of urban areas are more likely to be overweight than those of rural areas. So unfortunately, both our countries have the same problem, and that is that people do not exercise enough, and they have increased weight with the problems that this brings. Now, are there health implications, though, for physical inactivity? Yes. The World Health Organization ranks physical inactivity among the top 10 causes of death worldwide. We call this globesity, global obesity. The UK analysis shows that physical inactivity leads to almost 1 in 10 premature deaths from coronary heart disease and 1 in 6 deaths from any cause. So that's not very good. Regular physical activity can reduce the risk of death from coronary heart disease and stroke by almost 35%. That sounds better, so we should all exercise. It can reduce the risk of early death by 30%. Physical inactivity costs the UK healthcare system £1.2 billion, which is about $1.6 per year. Can you imagine what we could do in the health system if we had $1.5 billion a year extra to spare, which we now spend because of the costs of physical inactivity? And the wider impact on the UK economy is £1.5 billion per year. So it's a huge cost. So it's not just the lives lost directly from the disease, but it's all the burden that's created from the financial cost of obesity. And although this is a communicable disease rather than a non-communicable disease, let's not forget COVID-19. Unfortunately, we now live in the age of COVID-19. And unfortunately, people who are consistently inactive, or even people who have inadequate physical activity, have a higher risk of hospitalization, of admission to an intensive care unit, and of death compared to patients who were consistently meeting physical activity guidelines. So basically, if you're physically inactive, you have a higher chance of dying of COVID. So why does this work? Well, we all know this. Weight reduction leads to lower blood pressure. It lowers your LDL, raises your HDL, lowers your insulin requirements. There's even evidence down to the physiological level of the capacity of blood vessels to dilate from regular exercise, improving and leading to improved oxygenation of the tissues. And we found that patients who've had a heart attack and participated in a formal exercise program had a 20 to 25% lower death rate following their heart attack compared to people who did not participate in an exercise program. So the UK government has made similar efforts like the Pakistani government. So one of the ways in which this has been fought here is to put salt into, put taxes onto salty foods and onto sugary foods, and we call it the sugar tax. There was even criticism of this on the news about affecting disproportionately the lower and middle income families, because they were more likely to buy food from outside rather than cook at home. And as a result, they would have to pay more money for their food. And I personally think that that is awful. You know, people should cook at home with healthy foods and healthy ingredients rather than be buying all their food from out and eating basically a diet that's based on salt and sugar. And the American College of Cardiology and the American Heart Association, in a joint statement, have said that the most important way to prevent atherosclerotic heart disease, heart failure, and AF is to promote a healthy lifestyle. And they've said that all adults should have a healthy diet, vegetables, fruits, nuts, lean protein, and eliminate saturated fats, red meats, and processed meats, and refined carbohydrates. And there is a guidance on the amount of exercise we should all do in a week, and it has to be at least 150 minutes per week of accumulated moderate intensity physical activity, or for those of us who can do vigorous intensity activity, 75 minutes a week is sufficient, which is actually not too much if you consider that this is cumulative and you can spread it throughout the whole week. And just 75 minutes of high intensity exercise can make a lifetime of difference. So also non-pharmacological interventions are recommended for all adults with hypertension. So we don't necessarily need to take pills. We can start the improvement by exercising and eating better. So the government took a school initiative to start tackling obesity in a young age. So the initiatives included introduction of the soft drink industry levy, so the sugar tax, taking 20% of sugar out of products, supporting innovation to help businesses make their products healthier, so money for healthier product development, updating the nutrient profile model so that it would be simpler for the people to see what they are eating, healthy options available in the public sector, so when you go to your hospital kitchen, for example, to get your lunch, you have healthier options. Supporting the cost of healthy food for those who need it the most, so basically benefits to allow people to buy healthier food, which tends to be more expensive than unhealthy food. Helping all the children to enjoy an hour of physical activity every day. Coordination of quality sport programs in schools. A new healthy rating scheme for primary schools. So basically, if your child's school is promoting a healthier lifestyle, it receives a higher rating from the government. So these are some initiatives that have been taken care of here to reduce obesity. And just to close off, the British Medical Journal published a very interesting article which is called Mammals, which are middle-aged men in lycra, like the gentleman on the screen here. And this is, of course, cycling, which has exploded in popularity here. And basically, they have concluded that running and cycling reduces heart disease and death from cardiovascular causes. But cycling, unlike just other forms of sport like jogging, reduces also death from all causes, not just from cardiovascular causes. Running doesn't do so. It's not entirely clear from the study why there is this subtle difference. People think that perhaps there is some metabolic stress from pounding on the footpath as you run, whereas cycling, because of course you don't have as much muscular load, perhaps reduces this metabolic stress. But certainly, again, it's a proof that exercising improves your life expectancy and your cardiovascular profile. So that's it from me. Just a very short presentation. Thank you very much. Just to conclude, it's been proven in the UK, like in Pakistan, that there is a significant obesity issue. It has been proven that increasing your exercise levels and improving your diet and your healthy lifestyle in general reduces cardiovascular disease and increases life expectancy. And the requirements to improve our life expectancy are not too vigorous. They're common sense things that we all can do, and education plays a significant part in all of this. It is important to start educating children from a young age and make sure that they understand from a very young age that a healthy lifestyle will serve them for life. So thank you very much.
Thank you very much, Dr. Nicholas, for such an enlightening talk. Now, I would request Honorable Professor Dr. Nasir Ahmed Samoor. Major General Nasir Ahmed Samoor is Consultant Interventional Cardiologist and Physician at AFIC and NIHT. He is also Professor of Medicine and Cardiology at National University of Medical Sciences, Rawalpindi. Dr. Nasir Ahmed Samoor is going to discuss about diabetes, ischemic heart diseases, and their impact on heart failure.
I'm very thankful to the organizers for providing me this opportunity. Seniors, ladies and gentlemen, I'm going to talk about effect of diabetes mellitus on cardiovascular diseases and heart failure. This is a list of certain conditions which can be attributed to diabetes mellitus, which are cardiovascular conditions can be attributed to diabetes mellitus some way or the other. Now coming to the definition of the heart failure, it's a clinical syndrome that results from any structural or functional abnormality of ventricular filling or ejection of blood. Here you can see a normal heart, and this is a dilated heart with reduced ejection fraction, and this is a hypertrophied heart with preserved ejection fraction. Heart failure can result because of any abnormality of pericardium, myocardium, endocardium, valvular structures, or coronary arteries. And its cardinal symptoms are shortness of breath, fatigue, and lack of effort tolerance. Heart failure is classified into heart failure with preserved ejection fraction. And in these patients, ejection fraction is equal to or less than 40%. They're also known as systolic heart failure. The other category is heart failure with preserved ejection fraction, where we find ejection fraction of equal to or more than 50%. They're also known as diastolic failure. And as far as prevalence is concerned, both these types are almost equal. and one needs to exclude other causes of symptoms of heart failure in this diastolic failure component. There is another variety of patients who land in between, and their ejection fraction ranges from 41 to 49%, and they are known as borderline or intermediate heart failure. And there's a fourth category which previously had a reduced ejection fraction, but then with treatment they improved to have ejection fraction of more than 40%. Now these stages determine the development and progression of heart failure, which are stage A, B, C, and D. Stage A is just the risk factors. Stage B is structural disease without symptoms. And stage C is structural disease with current or past symptoms, whereas stage D is refractory heart failure. And these stages manifest in the form of NYHA functional class, which ranges from class 1 to 4. And as I said, stage A and B are usually asymptomatic, and stage C can have class 1 to 4 symptoms, but stage D is always class 4 symptoms. And the annual mortality of heart failure increases with the progression of the stage of the disease. Now, a little bit about the epidemiology. In 2015, there was, they estimated 415 million people with diabetes aging 20 to 79 years. And this figure is expected to rise to 642 million by year 2040. There are about 5 million deaths which are attributable to diabetes annually, and the total annual global health expenditure due to diabetes was estimated to be $673 billion US. And the prevalence of diabetes in Pakistan was found to be around 15%, and pre-diabetes around 12%. Now, this is province-wise prevalence of diabetes in Pakistan. As you find here, Sindh is the province where it is most prevalent, whereas KPK is on the lower side. Now, this is the age-wise prevalence of diabetes in Pakistani population, more than age for 25 years. As you see, this is most prevalent in this decade, which is 65 to 75 years of age, and this is around 22%. Now, a little bit about prevalence of heart diseases. As you know, General Farhan has just discussed about the global burden of ischemic heart disease, and Southeast Asia, which is our region, is having the quarter of the world population, and there are about 65% of the global burden of disease is found in this region. Epidemiological data on the incidence of and prevalence of heart failure in Pakistan is quite limited, and they estimated about 2.8 million patients with heart failure in 2006. And there was another small registry from Lahore in which they found the mean age of hospital failure admissions of 54 years, which was 18 years lower than that of the reference US population. This is a Scottish study which compared different ethnic groups for their health issues. And here you can see they compared the Pakistani men and women with the Scottish men and women. And Pakistani men and women they were found to have 35%, 58% higher prevalence of heart failure, respectively. Regarding the relationship of diabetes and heart failure, as far as the epidemiology is concerned, there has been a well-established association between diabetes, mellitus, and heart failure, and that is mainly because of coronary heart disease and hypertension. Diabetes and heart failure do occur concomitantly, and the prevalence of diabetes and heart failure ranges from 10 to 47%, 40%, more than 40%, and 9 to 22% in different studies. As far as type 1 diabetes is concerned, this is also very important as far as the incidence of heart cell failure is concerned. Rather, it has 4 times increased prevalence of heart failure as compared to the normal population or controls. Worse glycemic control was associated with increased risk of heart failure in graded fashion. Evidence of decreased cardiovascular events such as non-fatal MI, stroke, cardiovascular death, angina, coronary revascularization, and mortality with the intensive insulin therapy was established. And there is very little data on the effect of intensive glucose control and the risk of incidence of heart failure. As far as type 2 diabetes is concerned, it leads to 2 times increase incidence of heart failure in men and 4 times increase in incidence of heart failure in women. The risk of heart failure associated with diabetes might be even higher in younger adults. Here you can see age-wise prevalence of heart failure. And this was a study which was conducted over 72 months. And they found that this was the age group which was 75 to 85 years, where the incidence of heart failure was maximum. And this was 2 times, the diabetics had 2 times more incidence of heart failure as compared to the non-diabetics. And if you focus on this figure, here, this is the group which had age less than 45 years. And this group had 11 times more incidence of heart failure in diabetics rather than in non-diabetics. This is again age-wise rise in the heart failure. Here you can see in younger age group, there is 11 times more incidence of heart failure. But with the increasing age, the incidence of heart failure decreases, and it is just 1.2 times in this very elderly group. Now, this is the effect of control of diabetes. And if you see here, if with each increase of 1% increase of HbA1c, there is 8% increase in the incidence of heart failure. But this fact is established only in patients who already had established coronary heart disease, and it's not well established with the patients who with coronary heart disease. Patients who did not had established coronary heart disease, they were found to have this relationship. But the patients who had established coronary artery disease, this was not well established. Here you can see the another slide which shows the effect of control of diabetes. With every 1% reduction in HbA1c, there is around 14% decrease in the fatal and non-fatal MI and 16% decrease in heart failure. Now this is this flow chart shows the various factors which are lifestyle factors, predisposing factors, social, economic, and other factors leading to development of risk factors for coronary atherosclerosis, atherogenic dysplasia, insulin resistance, abdominal obesity, general obesity, hypertension, tobacco use, air pollution. These all factors can contribute towards development of LV hypertrophy and diastolic dysfunction and systolic dysfunction. And this can lead to premature coronary artery disease, and all can contribute towards premature heart failure, leading to heart failure, death, disability, reduced functional capacity, healthcare costs, loss of productivity, and economic burden. And this is perpetuated by suboptimal prevention, detection, and management. Now, as far as the pathophysiology of heart failure in diabetic patients is concerned, this has two prongs. One is the development of coronary artery disease leading to ischemic cardiomyopathy and heart failure, and the other is development of diabetic cardiomyopathy. And this accounts for about 10 to 15% of the patients. As far as diabetes and coronary artery disease is concerned, type 2 diabetes patients are 2 times more likely to develop coronary heart disease as compared to matched controls. And in this study, you can see there are 2 groups of patients based on the risk factors. Group A is 2 or more risk factors, and the group B is 1 or less risk factors. And you can see the overall prevalence of coronary disease was 65% in both the groups, but triple vessel disease and diffuse disease was more prevalent with group A, and it was less prevalent with group B. Now, this is the mortality, coronary heart disease mortality by age in type 1 diabetics. And you can see the type 1 diabetics had 4 times more mortality as compared to non-diabetics. I have already touched diabetic cardiomyopathy. This is defined as presence of diastolic or systolic dysfunction in a patient with diabetes mellitus without other obvious cause for cardiomyopathy, such as coronary artery disease, hypertension, or valvular heart disease. There is going to be left ventricular hypertrophy, which is thought to be caused by insulin resistance, hyperinsulinemia, and it is an important characteristic of diabetic heart. Hyperglycemia contributes to activation of local RAS, which is renin angiotensin aldosterone system, which leads to overproduction of angiotensin 2 and aldosterone, which induces cardiac hypertrophy and fibrosis and exacerbates diastolic dysfunction. There is a limited incidence on the prevalence of diabetic cardiomyopathy. In one study, they found it to be around 17%. Now, silent ischemia and silent infarction can occur in diabetic patients because of autonomic neuropathy. And now we come to heart failure as a risk factor for diabetes. I mean, it is vice versa. Diabetics can develop heart failure, and heart failure patients, heart failure itself can contribute as a risk factor for development of diabetes mellitus. And here are 2 trials, landmark trials. This is CHARM program and this is emphasis trial. In this trial, it was, in this trial, they found the incidence of diabetes mellitus in patients who were non-diabetic and had heart failure. It was 3 times, whereas it was 2 times in emphasis trial. Now we come to the clinical outcomes. These are the 4 patient groups in this study, and they are non-diabetics, pre-diabetics, newly diagnosed diabetics, and previously diagnosed diabetics. And you can see the incidence of cardiovascular death as well as heart failure hospitalization was more prevalent in diabetics and newly diagnosed, previously diagnosed diabetics and newly diagnosed diabetics. Now we come to the management of diabetes in heart failure. According to this meta-analysis, they found there was no significant difference in the risk factor of heart failure between intense glycemic control and standard treatment arms. ADA recommends HbA1c of less than 70% for majority of adults with diabetes and less than 8% for patients with significant comorbidities. Whereas AHA recommends target range of HbA1c from 7 to 8% for most patients with heart failure. Here you can see the goal of achievement of HbA1c relaxes with the progression of the stage of heart failure. Better is the stage, more tighter is the goal which is required. And once there is limited life expectancy, stage D heart failure, end stage kidney disease, and other comorbidities, there is relaxation of the goal of HbA1c as far as the treatment of diabetes is concerned. Here is a systematic review which is indicating the importance of metformin. So old is gold and metformin is still very much in. And in this systematic review, they have demonstrated there is about 20% reduction of cardiovascular mortality in patients with diabetes and heart failure. And here you can also see there is mortality reduction as well as a reduction in the hospitalization in metformin group as compared to controls. Now there are few tips about the use of metformin. If the creatinine, if the GFR is more than 60%, no issues. If GFR is between 45 to 60, more renal checks should be done more frequently. If it is between 35 to 45, then only a very low dose can be used, and it is contraindicated if the GFR is less than 30 ml. These are few other contraindications to the use of metformin in heart failure patients. This is the second, which is relatively recent group of drugs, which is used in the treatment of diabetes mellitus. These are sodium glucose co-transporter 2 SGL2 inhibitors. They demonstrate a reduced risk of heart failure hospitalization in patients with diabetes. It is reasonable to consider to use them as a part of preventive strategy in patients with diabetes at high risk for heart failure. This group reduces the risk of heart failure hospitalization by 35% in patients with and without heart failure at the baseline. They are also good glucose lowering medication choice in patients with established heart failure and diabetes mellitus. According to Origin trial, they examined insulin glargine versus standard care in type 2 diabetic patients with high risk for CVD, and they did not demonstrate any benefit of this insulin over the control. Insulin usage in high-risk patients does not lead to adverse cardiovascular outcomes or to increase heart failure. Improving glycemic control with insulin has not been shown to reduce the elevated risk of heart failure that exists in diabetic patients. These are a few other groups of drugs which can be used. I will just skip over. And this is the summary of various trials about the usage of various different groups of anti-diabetic medicines. And you can see this is the group which is SGLT2 inhibitors. And this shows a mortality as well, reduction in the major adverse cardiovascular events, as well as heart failure hospitalization. Now, this is a case scenario, a 68 years old woman at high risk of heart failure with diabetes, hypertension, hyperlipidemia, and coronary artery disease, creatinine 1.1, GFR 55 ml. The best option for this patient is metformin, SGLT2 inhibitor. GLP-1 receptor antagonist may increase the risk of cardiovascular events. Second lines are DPP-4 inhibitors, sulfonylurea insulin, and TZDs should be avoided. This is a second case, 78 years old man with diabetes, recently diagnosed stage C heart failure with reduced ejection fraction caused by non-ischemic cardiomyopathy EF 30%, creatinine 1 milligram, and GFR 77 ml. The best option for this patient's diabetes is metformin, SGLT2 inhibitors, and second line are sulfonylurea and insulin. And these are the groups to be avoided in these patients. Case 3, 59 years old man with diabetes and recently diagnosed stage C heart failure, EF 60%, creatinine 1 and GFR 71. Again, the best option are same and second line are same. And this is case 4, 72 years old woman with diabetes stage C heart failure with reduced ejection fraction caused by ischemic cardiomyopathy, EF 35%, creatinine 2, and GFR 25. Here, insulin is the best option, and second options are these groups. Coming to the management of heart failure in diabetic patients, these are the, as you all know, these are the commonly used groups of drugs for the management of heart failure. They are ACE inhibitors, ARBs, ARNI, beta blockers, spironolactone or eplerenone, and secondary treatments as indicated ivabradine and hydralazine nitrates and digoxin. These are the patients in which multiple randomized controls, they compared the different drug groups, and you can see the reduction of mortality and hospitalization in these groups, and their percentages benefits are shown here. Now, this is a trial which showed the superiority of ARNI, which is angiotensin receptor neprilysin inhibitors, over the conventional ACE inhibitors and ARBs. And this is now well-established treatment of heart failure. This is the summary of the treatment of guideline-directed therapy for the stage C and stage D heart failure. Initially, we start with ARBs or ACE inhibitors, beta blockers, and diuretics. And if there is persistence of symptoms, we proceed on to addition of aldosterone, conversion from ACE inhibitors and ARBs to ARNI, and we can start hydralazine nitrate group in black people, and we can consider implantation of ICD and CRT. And if they are non-responders, these are the options: palliative care, transplant, and LVADs. Now, the take-home message is diabetes increases the risk of heart failure development. Diabetes is relatively more prevalent in heart failure patients. Diabetes increases the risk of mortality and hospitalization in heart failure patients. SGLT2 antagonists provide maximum reduction in mortality in heart failure hospitalization patients with diabetes and heart failure. Metformin is safe and effective in reducing mortality and heart failure hospitalizations. Insulin neither increases nor decreases heart failure mortality and hospitalization. Thiazolidinediones are contraindicated in heart failure patients. The management of heart failure and diabetes is the same as management of heart failure without diabetes. Prevention is always better than cure. Thank you very much.
Thank you very much, Sanjay Samur. Our last presenter for this session is Honorable Professor Dr. Abdul Hamid Siddiqui, Consultant Cardiologist, Physician, and Deputy Director Academics at AFIC NYHD. He is also Professor of Medicine and Cardiology at the National University of Medical Sciences, Rawalpindi. Dr. Abdul Hamid Siddiqui will share his thoughts on hypertensive heart disease, its prevention and control. Thank you.
Bismillahirrahmanirrahim. I'm grateful to organizers for asking me to give a talk on hypertension. My talk has already been made easier by Professor Han Tayyib, who already alluded to some aspects, covered some aspects of the hypertension. Hypertension is a silent killer. It might be disturbing for the audience that if I say that those who are more than 18 years of age, half of them might be hypertensive if we take more than 120/80 as the cutoff line. But never mind, if it is still less than 140/90, the treatment may not be required. So hypertension, as already discussed, is a serious medical condition, and more than 1 billion people all over the world are hypertensive. And unfortunately, 2/3 out of them are living in low and middle and low income countries, as is our part of the world. According to 2015 estimates, 1 in 4 men and 1 in 5 women had hypertension, and fewer than 1 in 5 people with hypertension have the problem under control. The hypertension has been said a disease of halves, but unfortunately it's a bad half, not the better half. Half of those who are hypertensive, they do not know that they are hypertensive. Those who are hypertensive, only half of them are on medication. And those hypertensive who are taking medication, only half of them are under control. So it's a major cause of premature death worldwide. One of the global targets of NCD disease to reduce the prevalence of hypertension burden is by 25% by the year 2025. In 2015, around 15 million died from NCDs, and the major contributor was hypertension in these deaths. And these all premature deaths were preventable. As I already mentioned, as a single risk factor, it is the leading preventable cause worldwide, but it still counts for more than 10 million deaths every year. It kills more than any other condition and more than all the infectious diseases combined. So just comparing the disease burden from year 2000 to 25,000, it has increased. It has gone to 29% of the world population. There were 972 million hypertensive in year 2000, but now it has increased more than 1.5 billion. And the difficult part is that the increase has been in our part of the world, that is in the Asia, Africa, which are developing economies. So hypertension treatment is almost responsible for 10% of all healthcare spending, and it is going to account for almost $370 billion for the treatment of hypertension worldwide. So world map showing the prevalence of disease, as I already mentioned, it is mainly in our part of the world and in the African region. So the lowest prevalence rates are in America, but they are highest in Africa, and Southeast Asia is not far behind. The prevalence is still very high in our neighboring countries, that in the Middle East is almost sitting more than 23% in most of the region, including Pakistan. As far as the burden of disease in Pakistan is concerned, it's still very high. According to one estimate, it is around 26.34%, and it is higher in the urban population as compared to the rural dwellers. So what are the risk factors for the major risk factor, that is hypertension? There are different factors like the social determinants and drivers, the globalization, urbanization, aging, and income, education, and housing, and crowding. Then there are certain behavioral factors, that the unhealthy diet, tobacco use, physical inactivity, and other use of alcohol. And there are certain metabolic factors, like as just mentioned by Professor Nasir, the diabetes, hypertension, they go side and side. Obesity, lipids, and that's what is the effect of this of all these risk factors? Hypertension alone is responsible for almost 45% of all deaths because of cardiovascular disease, and almost 50% deaths because of strokes are the contributing factor is hypertension. And as you can see here, the risk factor which lead to development of hypertension, almost 81% are diet related. That's obesity, high sodium intake, and low dietary potassium. So as far as the definition of hypertension is concerned, as I will mention, anything beyond 120/80 is considered now hypertension. The American Heart Association is more stringent in these criteria, but anyway, some of the parameters on which we diagnose hypertension are depicted here. Any office blood pressure recording more than systolic 40 and greater than 90 is considered as hypertensive. But in certain cases, these figures might vary. There might be certain individual who might be labile hypertensive. For these individuals, there is a recommendation to use ambulatory blood pressure monitoring or home-based blood pressure monitoring. And their cutoff points are, on average, in ambulatory patients, it is 130/80, or during the daytime, 130/85. And in home-based, it is considered more than 135 systolic and more than 85 as the hypertensive cutoff point. Well, different type of hypertension. Most of the cases we do not know the cause. In those cases, we know the cause. It's called secondary hypertension. Then there might be malignant hypertension, gestational white coat, and there's another entity now recently been added, the mass hypertension. Secondary hypertension Could be because of different reasons. We know in primary hypertension, we don't know the cause. And some of the key factors or secondary causes of hypertension are the renal gland tumors, the coarctation of aorta, obstructive sleep apnea, illicit drug abuse, thyroid diseases, and kidney diseases. There are certain variation in the blood pressure response or in different parts of the world, particularly Southeast Asian, and in the Black population, the morning surge is high. Similarly, nighttime hypertension is more common when we compare with the Europeans. Similarly, the Southeast Asian, they are more sensitive to the salt. So because of that, they have a higher stroke prevalence, more hemorrhagic, and they have more chances of developing non-ischemic heart failure as compared to the Western population. So the management of hypertension in Southeast Asian, although the drug treatment remains the same, but still it might be difficult as compared to the Western population. Now, certain definite criteria based on a different organization, the American Heart Association. I've just depicted here the comparison of the International Society of Hypertension and American Heart Association criteria. The AHA is more stringent. So anything beyond 120/80 is hypertension, although it is labeled as elevated. If it is still between 120 and 129 and between and more than 80 to 89. While in case of International Society of Hypertension, they have labeled the elevated category as the high normal, but the readings are different. So there's grade 1 and grade 2 based upon these criteria. It is important to record blood pressure in a standardized setting, because once you label the individual as hypertensive, then you're sort of signifying that he has to adopt a lifelong measures to cater for the raised blood pressure. So it has to be recorded in an office setting, in a serene and quiet environment. The arm should be supported on the table. The cuff should be at the heart level. And only then the recording should be done in a number of different settings. In the initial evaluation, the standing blood pressure should be taken. And in some cases, the unattended blood pressure should also be recorded. So if it is less than 130/85, the surveillance may not be required. But if it is between 130 to 159 and 85 to 89, you have to confirm it in different settings in office recording. If the patient is going to have a blood pressure more than 160/100, it has to be confirmed within a few days, and treatment may have to be started. Well, there are different variation in the recording of blood pressure in different settings, but it should be done in recommended standardized setting. At the same time, in the initial recording, hypertension-mediated organ damage should be, if it is there, should be recorded. Screening should be done for that, because that accrues more complication as far as the hypertension is concerned. And combining other risk factors almost doubles or quadruples or even many increases the risk of complications many times. So in which cases we require ambulatory or home-based blood pressure monitoring. These are the cases with white coat hypertension, or in those with drug resistance, with labile or episodic hypertension. These are some of the conditions which should be met before we go for use of ambulatory or home-based blood pressure monitoring. Now, we know that the control of hypertension is extremely important, as I already alluded to, that only half of those who are hypertensive, they have good control of blood pressure. And this is some of the figures, as I already mentioned, that out of hypertensive, only less than only 47% are aware of it, and those are receiving treatment, only 14% are under good control. So what is the impact of treating hypertension on heart disease and stroke? Even a 10 millimeter reduction in systolic blood pressures It's going to reduce stroke by 27%, it's going to reduce heart failure by 28%, heart disease 17%, and premature death by 13%. As far as the management of different categories of hypertension is concerned, the Professor Farhan already mentioned a few points. I'm just going to give a passive reference to these. In category of elevated or pre-hypertension or cases, we may not require any drugs. Simple education or exercise or healthy lifestyle may be enough to bring it down. Similarly, adapting dietetic approaches to stop hypertension, this famous healthy diet pyramid is good to decrease the blood pressure in most of the cases. So this is just a slide to summarize in those cases in which the hypertension is well established. Those who have more than blood pressure 160 and 100, they are to be considered for medication, immediate medication. But in those who are in grade 1, depending upon the risk factors, drug treatment in low or moderate risk patient without cardiovascular disease or CKD diabetic might be or without target organ damage might be done over a period of 3 to 6 months with lifestyle modification. In those countries where the resources are scarce as our, still we can wait for 3 to 6 months to put them on medication. Only the lifestyle modification and healthy lifestyle may be enough to monitor them for a certain period of time. These are some of the guidelines from American Heart Association, which basically simplifies the cutoff mark of 140/90. Beyond 140/90, the treatment may have to be started, particularly in those cases with associated CKD or diabetes. These are some of the parameters at which level the treatment has to be started. So I'll not go into the details of drug therapy. This is just one of the algorithm adopted by International Hypertension Association and also adopted by the European Society of Cardiology, that in those who are less than 55 years of age, ACE inhibitors or ARB might be the good starting drugs. In patients who are non-Black or Caribbean, diuretics and calcium channel blockers might be are good as a starting drug for effective therapy. The drugs can be combined in different combinations as in cases of step 2 or stage 1, stage 2 or grade 1 or grade 2 hypertension. So some of the targets of blood pressure, which has been highlighted by American Heart Association or JNC8, mostly it's good to remember the figure of 140/90. Those who are more than 60 years of age, less than 150/90 might be enough. So the AHA or GNC8 is stringent as far as the diagnosis of hypertension is concerned. Anything beyond 120/80 should be considered for drugs or lifestyle modification. But as far as the targets is concerned, they are a bit lenient for the cutoff points. Similarly, as far as the NICE guidelines are concerned, almost similar figure, but for diabetes, they have the cutoff mark for diabetes for NICE is 140/80, and with renal disease, it is 130/80. Now, these patients can be followed at regular intervals. I'll quickly, because of the paucity of time, I quickly go through these. Those who are well controlled on blood pressure, they might be called for review after every 3 months, and then after every 3 to 6 months. But if it is not controlled, they have to be called back quickly. Well, when the hypertension becomes emergent or urgent, I think the emergency physician has to do some work at emergency department. I'll not go into the details of this. So some of the complications which we can avoid by treating hypertension are basically, as I already mentioned, the main brunt is on the stroke and coronary heart disease, because the hypertension is a contributing factor in almost 50% of all deaths because of cardiovascular disease, and almost 45% for cardiovascular disease, and almost 50% with cerebrovascular disease or cerebrovascular accidents. Well, as far as I think in the initial inaugural session, a lot has been said about the prevention. So I'll quickly go through these slides. We can make 50 by plus 30 as 100 if we can increase the global control of blood pressure from 14% to 50%, or reduce the global dietary sodium intake by 30%. So this can save almost 100 million lives in the next 30 years. Well, there are different strategies to prevent hypertension. Basically, it's the different modes of different stages of prevention, the primordial, the primary, the secondary. And these are all important to save life and to reduce the global burdens of disease. That is with particular reference to hypertension. We have to act at primary level, primary care physician level, bringing on small changes in risk factors in population, and basically following a mass approach as already highlighted in his initial lecture by Professor Farhan. So we have to identify risk factors, and then we have to give specific advice pertaining to the motivation to do the positive action against all the identified factors. Primordial prevention, the identifying or targeting at before the onset of the risk factors. Secondary prevention. So some of the specific intervention which have already been highlighted, that is dietary changes, smoking, blood pressure, physical activity, and so on and so forth. So just to highlight what quantitative benefit this lifestyle modification can present. This is a common slide that you commonly see, but you can see that without medication, how much decrease in both systolic and diastolic blood pressure this can bring about. So reducing 1 kg weight can bring 1 millimeter systolic and diastolic blood pressure down. Similarly, we have to focus on tertiary prevention in those who are already hypertensive. We have to check them regularly to avoid further complications. And just a few points on the community approach to for the prevention of primary hypertension. The community approach to hypertension prevention has a high degree of generalization and cost effectiveness. And as far as the National Action Plan for NCDs in Pakistan is concerned, the program focuses on attention on improving the quality of prevention program within the primary and basic health sites. One of the features is to integrate concerted primary and secondary prevention program into health services as part of the comprehensive and sustainable, scientifically valid and resource-sensitive program for all the categories of healthcare providers. Surveillance of cardiovascular risk factors is important as part of the NCD surveillance system. So what is the WHO response? It has already been highlighted. I'll just quickly go through the slides. That is the Global Action Plan between 2013 and 20. The basic parameters or pillars of that prevention strategy is surveillance, prevention, and management. And the goal is to reduce preventable and avoidable burden of morbidity, mortality, and disability due to NCDs by means of multi-sectoral collaboration and cooperation at national, regional, and global levels. So these are some of the objectives which has already been highlighted. As far as the hypertension is concerned, the target for 2025 is to reduce the burden of disease by at least 25%. So these are some of the global health initiatives which have been taken in collaboration with WHO. I'll quickly go through these. These are the global health initiatives. So to summarize, hypertension is a silent, invisible killer. Increasing public awareness is a key, as is access to early detection. Countries as ours need systems and services to promote universal health coverage and support healthy lifestyle, eating a balanced diet, reducing salt intake, getting regular exercise, and shunning tobacco. Access to good quality and inexpensive medicine is vital to reduce complications. Thank you very much.
Thank you very much, Sir Siddiqui. Now we will take a quick Q&A session. If we have any questions, our presenters can answer them. Any questions?
Thank you very much. It's a very quick question and a comment, because I would like this to be recorded, because the recommendations that would be formulated at the end of this conference must, if my conjecture is correct, if it is supported by the panel here, must be included in the final recommendations of this conference. One point, the comment that I would like to make, particularly regarding the heart failure, the studies that have been quoted previously from 2006 and 2005 actually show a very small figure of 2.8 million people suffering from heart failure in Pakistan at that time, which may be, the figure may be much higher now, but primarily that figure relates to heart failure with reduced ejection fraction. It does not account for the intermediate variety and the ejection fraction preserved heart failure. So a very large segment of heart failure patients are not included in that figure, and that must be made relevant and part of the record. And any future projections of heart failure must account for all the three different types of heart failure as per the latest guidelines, and proper guideline as to how a person has to be labeled as heart failure needs to be outlined. And in that regard, I just have a question as well, and I would like the panel, all three very eminent cardiologists sitting here, to make a comment on this. The echocardiogram, that is actually the hallmark of defining heart failure, nowadays in the most of the settings does not really account for the segments who have preserved ejection fraction or maybe borderline ejection fraction, and they are not declared as heart failure. Particularly with the background of diabetes mellitus, obesity or diabesity or metabesity. So probably some relevant kind of information needs to be included before the echocardiogram is performed. And the echocardiogram, if the technical experts can say whether there are certain parameters doing the echocardiograms on a routine basis which can actually account for this preserved ejection fraction, like systolic ejection time calculation or fractional shortening or whatever the specific parameters are, which should be made part and parcel of the actual report which comes to the clinician's desk to define whether the person suffers from heart failure or not. Your comments, please.
So your point is very valid. Back in 90s, when we used to come across heart failure patients in the coronary care unit, many of them had normal ejection fraction, but they still would be in pulmonary edema. And they would come with chest pain, some EC changes, normal LVEF, and they would have frank pulmonary edema. And we didn't know what has happened. And but then, slowly, gradually, the evidence started to emerge that the problem with these people is the diastolic dysfunction. There's impaired relaxation, and there are, in cath we used to measure if there is raised LVEDP in presence of normal LV systolic function, then we used to label it as diastolic dysfunction. And echo, we have very clear markers these days, like we study the E and A waves on Doppler, and we can tell actually what is the grade 1, grade 2, grade 3. There are the 4 grades of diastolic. I think we are now much wiser. We have now other tissue Dopplers imaging. We can gauge the diastolic dysfunction, and that we can very well correlate with the heart failure now. But true, in past we had no clue about those patients. But no, now echo is a very good investigation. If done properly and in a proper manner, recording all these relaxation times and E and A waves and tissue Doppler, we can have very good evidence.
So you agree that a minimum standard of care would be that an echocardiogram done on a suspected patient must include all these parameters that you have
Absolutely.
mentioned. All right. And one more question related to this. Role of pro-BNP and its value in establishing heart failure, particularly in conjunction or alone with the echocardiogram.
Pro-BNP is a very good test. It helps us decide about the heart failure is there or not in case of bad X-rays. The problem is cost. It's an expensive test, and if we start doing like these troponins, every patient in AFIC emergency undergoes 2 or 3 troponin tests, and it costs some money. So we haven't started pro-BNP on large scale just because of the cost. It's an expensive test, but definitely it is a very, very useful test. It helps us decide in a lot of patients of bronchial asthma, COPDs, that these patients are suffering from heart failure. Thank you.
Thank you, sir. Now I will request Honorable General Kiani to kindly come to the stage and hand over shields to our Honorable Chairperson, Co-Chairperson, and the participants. Sir Ashraf, kindly if you could hand over the shields to our participants. Sir Nasir. And Sir Siddiqui, kindly please come to the stage.
I request the chairman to give the shield to Dr. Farah.
Thank you very much. Now this concludes our session. I would request our Honorable Chairperson, Professor Dr. Mohammad Ashraf Khan, and Co-Chairperson, Professor Dr. Farhan Tayyib, to share their views about this informative session.
First of all, I take this opportunity to be here. I feel very good to be here, and to thank the organizers of the conference who have done such a wonderful job, and that too in the times of Corona, and attracted such a good audience. So I once again congratulate them on their efforts. They have done a wonderful job. And their dedication and devotion is in implementing this program is very commendable. This, you have listened to very good, very stimulating, invigorating speeches by the experts on the subjects, and they have covered the subject very well. And I'm sure that you must have benefited from their knowledge, and there are some take-home messages that I would like to share with you. One of that thing is that we have learned today that cycling is one of the best exercises, and it not only reduces the risk of the heart disease, but it reduces the risk of the other diseases, including the giants and the cancer and so many other things. So I think you should get together and go cycling together as groups, as students. I think you will benefit from that. Another thing that I have learned is that LipCard, which is going to be established in AFIC, is going to be the game changer. And once it is established, it will do a home research and national research, and we will be able to have the national figures about various diseases. And I hope that it will come into action soon. The MCDs, they are a man-made calamity. And Corona is a God-given scourge. So I think by doing your own homework and caring for your own self, you can get rid of the MCDs. But Corona, you have to take social distance. You have to wear the mask. That is not required in prevention of the MCDs. So I think do regular exercise, quit smoking, and it has been noticed that the smoking is getting very, very common in our younger population, especially the students, and some of it used to be very rare in the girl students, but now even the girls get to the smoking. And I think you should not smoke yourself, look after yourself, and also try and prevent your family from not getting to smoking. And help your family that they should quit smoking, and don't be passive smokers as well. And if you see somebody smoking, you can always should have the courage to stop him from that activity. Thank you very much.
Thank you very much. This concludes our session on cardiovascular diseases today. And now we'll proceed for a lunch break, and we'll meet at 2 o'clock.